one, I think, is best handled in two parts. Part one, please share your thoughts on the correction of tongue tie in children and its correlation to sleep breathing disorder.
You want me to start that one?
You should, because the medical opinion is probably, yeah, go ahead.
Well, okay. So as a general dentist in Edmonton, I had a lactation consultant come and ask me about 10 years ago why I'm not using my dental laser to release these infants' tongues so they can breastfeed. And she even brought her infant to New York to Dr. Kotlau to release the tongue so she could breastfeed. And she doesn't make a lot of money. So that was a big deal for get on a plane, go to New York. So I looked into it. I got trained by Dr. Kotlau, and I realized that when I took my dental laser and released that tongue in the infant, 80% of the symptoms of breastfeeding in the infant and the mother went away. Long story short, it's 10 years later, and I've done over 4,000 infant frenectomies. And when those tongues are fully released, we can see a craniofacial difference between those compared to the ones that have a tongue tie. So when I first started doing it, the medical doctors are like freaking out, get your laser away from my infants. And I'm like, sure, here, you take them. And then the parents would go to the medical doctor's office and they would do all their thing. And then they'd come back to me because I'm a dentist. I'm trying to do root canals and crowns and fillings. And then I got these moms breastfeeding in my clinic. But I really liked how it helped. And I never advertised for it. It just went like wildfire on Facebook. So now a lot of those same medical doctors that were worried about it are referring me patients because they're finding that clinically it just works. And my protocol to do stretches for 6 weeks after really reduces the amount of scar tissue you see in the literature. So so now the medical doctors are more open to it. There's lots of really great literature out of Stanford University and things like that. I go into a lot of detail with about that in my infant frenectomy course, which Dr. Witmans is talking about sleep apnea in kids. And so she knows a bit more from the medicine side.
So it makes sense that the tongue tie might play a role, but you have to take the whole thing in context, okay? Part of it is we're all biased from the lens we come from. And I'm not saying that fixing a tongue tie is wrong, but you got to wonder why that happened. We haven't figured out some of those things. I do see tongue ties that were fixed before and they were still restricted, or they need, multi-phase treatment and it hasn't been sorted. I think it goes back to that table or airway. You have to look at the whole thing and figure out what that role is. The tongue tie would certainly make a difference to start off with, and like anything, there's compensation. Can you, after an MVA or whatever, can you walk again or talk again or do all those things? Absolutely, but you have to put it in context of what's going on. If they have a craniofacial profile problem or a genetic syndrome, there might be limits to what that tongue tie release is going to do, or a kid that has low tone. So it's really important to put all of these different pieces in context, and that's why you're a trained professional with critical thinking skills to figure out what you're doing and how that works in the framework of what needs to be done to fix that garage.
Exactly. And it's really important to distinguish between a partially released tongue and a fully released tongue. So when I was a nurse and I worked in the case room, we were taught to snip the tongue if it was tied. And that was our training kind of, and we would take 100% tie and make it a 75% tie. But now as a dentist, and all you dentists know a lot about oral anatomy, you're working in the mouths every day. This is a really easy procedure for you. It needs to be fully released. And then just the protocol of doing it it can be really effective. So this thing is emerging as something, but as I said, there's lots of literature, and then we have an oral surgeon teaching the course that's going to review the literature and review all the different surgical options, scissors and Z-plasty and all the different things that you can do. And it's not, dentist has a laser, but you can do it with electric cautery or whatever way. But to leave the tongue tied is also an option with risks and benefits. And really it's up to the parents to decide which option they're going to choose. I hope that helps.
Those are good factual answers, lady. The next one's a little more complicated. It's a interprofessional communication problem. So here it is. How do we as dentists communicate with family docs the importance of nasal breathing and early correction of mouth breathing? Dr. Witmans, do you want to start with that one?
Sure. There's a really great book and a resource I'm going to point you to. It's called Breath by James Nestor, and it's called the New Science of a Lost Art. I might have gotten the title a bit wrong, but it's called Breath by James Nestor. It's a yellow book. And in that, he reviews the science behind nasal breathing. He has YouTube videos. His name is spelled Nestor. It's worth your time. Nasal breathing is important because that is where the air is warmed, humidified, and filtered. Without the nose breathing, your lungs become exposed to the environment, no different than your skin. So when the skin is limited or when the barrier is impaired, like with eczema or whatever else, you are prone to infections, just like the gut. When it's unhealthy, you are prone to infections and being unwell. So the communication, you know what? I teach the patients. Patients can advocate for themselves, and I have amazing colleagues that are willing to listen. Just say, hey, let's have a chat. You tell two friends, Clairol, for those of you that are old in this group, you tell two friends and they tell two friends, and so on and so on. And before you know it, it has permeated whoever. And if they don't listen, well, it is what it is. And when their patients feel better from advocating for themselves, they will come around to say, hey, what happened? What did we do to make things better?
And that's a really important question. The other answer to that is watching the live broadcast with Sanjeev Jain. I think it's just go to the scienceofsleepapnea.com, and we talk about that. The frustrations a dentist has trying to tell the medical doctor, well, look, this is really important and stuff like that. But I don't know if you guys saw this. This is the book that Manisha is talking about. If you can see it there. And I don't know if a physician will read that book.
Probably. You know what is really cool? There is one guy or one woman that he interviewed in New York, and she actually corrected people with scoliosis. Remember, scoliosis is a bent spine, idiopathic or otherwise. He interviewed a woman who helped people correct their spine or scoliosis with breath work and posture. And if you think about it, be no different than beating out a dent in a car. You can do that with pressure and time. It's pretty incredible. Right. The human body and Mother Nature together, it's an incredible invention. Like, by golly, it's just a matter of, asking Mother Nature to figure out how to help you get to the right place.
Yep. And it isn't amazing how we humans haven't figured out a better way than Mother Nature.
Oh, okay. Not a chance, man.
Well, the pressure is going to come from the patients now that this protocol, this treatment protocol is FDA cleared, because they're going to be looking for that. And then you don't have to explain it. The physician will just send it to you and you fix them and send it back, and they'll go, wow, how'd you do that?
Question number 3, one I've often thought about: does the tongue increase in size with increasing body size? In other words, obesity and tongue size. Is it related?
Yes, you can get fat deposition. There's a beautiful MRI you can look up on the internet of a morbidly obese person. That fat is everywhere. It's around the liver, it's in the tongue, it's in the neck area, everywhere. And weight loss doesn't always correct it. So in people that have had a bariatric surgery and had sleep apnea, it doesn't normalize their OSA to an AHI of less than 5. That speaks to the idea that there's end organ dysfunction. At some point, you cannot reverse the downstream impact.
Yeah, and the size of the tongue can be affected by not just fat deposition, but muscle, like I was explaining earlier. But as a nurse for 10 years, I didn't know that a person's tongue gained weight when they gained weight.
Yeah.
But on myself personally, I measure sleep studies every night. And if I'm 5 pounds up, my metrics change. So that's in my head.
Yeah. Well, all the other things too, right? Alcohol, smoking, diet, reflux, all of that makes a difference. We've even had people, I had a professional singer who didn't develop her sleep apnea till she stopped singing. And that was the beginning of her journey of obesity and sleep apnea and depression and
Wow.
anxiety and hypertension and blah, 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 blah. But it was within 5 years that she stopped singing professionally, and then it got worse. And because I asked her, I said, well, why didn't you have trouble when you were younger? Because the garage is too small. So I used to
Right.
be a professional singer. So she compensated for her form by function.
And
So-
you can see some of these references in that article we wrote, because both of those things, there's references to that, and you can see the science behind it.
Note to self, I should continue singing in the shower as I have for years,
Absolutely.
Just
Yes.
close the door.
despite what the dog says when I do it. Okay, next question. Would you recommend tonsil and adenoidectomy before ortho expansion?
That
TNA
is a
before
complicated. That is a complicated question. From a science point of view, there was a study published by Dr. Guilleminault, the late Dr. Guilleminault, where they did both. They did the rapid maxillary expansion first and then a TNA, and then the other way where they did a TNA first and a rapid maxillary expansion, and both were needed for complete cure of sleep apnea. So I think it depends on what happens. If they see Dr. Heit first or whoever ortho, they might do the RME first and refer to an ENT, or an ENT might do a TNA, and then they come to me and I say, oh, you should go, have the RME done, or the ENT might refer, or the family doctor. And sometimes they need both because it is both form and function, and it's structural. But Dr. Bhattacharjee review of 500 and some kids showed that when you look at kids that have had adenoids and tonsils removed and you study them a year later, a bunch of them that still have sleep apnea despite having their tonsils and adenoids removed were obese, older, had allergic rhinitis that didn't bear out in a multivariate analysis, or they had asthma. And we didn't ask about craniofacial profile or family history of asthma, because those two would also tip the scales for persistent sleep apnea.
So clinically, what I've been finding is, with a lot of the dental devices, that it's true. If you combine the actual maxillary expansion with removal of the obstructive tissues, then you get a better result. But it takes a long time in Edmonton anyways, for the patient to get into the ENT. And then once they say, yes, you need your tonsils out, and once they get scheduled and go in, and if the patient starts this Vivos Care treatment, I've actually seen the tonsils and adenoids shrink to the point where they're not going to put them under an anesthetic to take them out, because part of what it does is grow the nasal airway volume and enable them to nose breathe with their lips together and the tongue up in the palate. So there's a risk of going under a general anesthetic, a risk of this surgery. And I feel like if there's a non-surgical, non-inflammatory way to treat this condition, that should be done first. But if the tonsils are so obstructive, like the article I wrote, where her AHI was 113, they took the tonsils out, it went down to 70. Well, that's better than 113, but it was the DNA that cleaned up the 70 down to 1.
So again, it depends on what is doing what. So I, practically speaking, what would influence me in the office is if their moms and dads have had their tonsils and adenoids removed. I say when and what age. It's like, wow, the apple doesn't fall far from the tree. If mom and dad needed it, chances are that the kid might. But if there's a wait list, even in that time, I would send to the other, to the dentist or the airway person to see what we can do in the meantime. I send to the myofunctional therapist. The data is more robust in adults, but I think it's emerging for kids. And I would treat inflammation. So I address their allergies, their snotty nose with nasal airway clearance, treat any potential of asthma if it's there. Even in that, 3 months of anti-inflammatory therapy normalizes their tonsils, but it still doesn't fix the malocclusion that needs to be addressed by Dr. Heit.
Well, that's a great segue to the next question. I think we hopefully still have Dr. Mohammed Hamid in the audience. He sends in this observation, and if he's still with us, perhaps he could speak to it quickly. He says, I've done an anecdotal study, both pediatrics and adults, trying to find out if there's any correlation between tongue-tied and hypersensitive gag reflex. He says all of them had a gag reflex that decreased significantly post-frenectomy.
I think clinically, I would think that the people that have a very profound gag might have a posterior tie. I don't know, Dr. Heit would know more, but they do gag easily. And I would say that now that I see it, know it, I'm mid-face deficient too, and so is my daughter. And I think it has to do with mid-face deficiency.
There
So
you
it
go.
depends on whether it was the tongue tie that caused the mid-face deficiency, chicken or egg problem, but
Right.
I would agree that I'm again more likely to send to a dentist just from the hypersensitive gag to say, you know, there's something wrong with your garage. You need to go
Yeah,
see someone
right.
else to make this okay.
Well,
What do you
Dr. Yeah, like Dr. Guillemot has published a ton of stuff, like out of Stanford University, and all his mentors that he left behind. There's a lot of stuff out of there on that topic.
But not specifically the gag.
gag,
So
yeah.
if it is there, you should publish your stuff. That would
Yeah.
be really
Well,
important.
the next one is very simple. How does medicine and dentistry use pulse ox differently? Or how do each of the professions use pulse oximetry?
Well, I use it to define, to help me determine the severity of hypoxemia and to determine if there's any underlying lung disease. I don't know if dentists use that.
So I do. I just take a pulse ox on admission.
Okay.
Like I did one, it was 93 today. I'm going, wow, that's not that great.
Yeah, like I don't know what you do with it. I think it's basically a flag, like a thermometer, right? It tells you if there's a problem or not.
Yeah.
And you decide if you're gonna have your appropriate lung doctor or sleep doctor or whatever person involved in managing their care. Any saturation under 93% in an adult or 92 or less, I would wonder about underlying lung disease or obesity, hypoventilation. In a
Right.
child, anything above, anything below 95 awake tells me that there's something else going on. And then the amount of time with saturation below 90 at night is a marker of sleep apnea or underlying cardiopulmonary disease. And that's a whole new topic that we can't
Right.
cover in the time we have
See,
left.
she's an encyclopedia.
Yes, she is. Why do we have her back? What's the protocol in Ontario for dentists using HST for dental patients? I'm not, I don't have a hard time saying that in my personal opinion, Ontario is the black hole of healthcare. We're not allowed to do very many things. We can't have a cone beam, on and on it goes. For those of us who are doing this of a serious nature, I use it as a screening tool. I use it as a titration device. It's helpful for me to educate our patients, because so many times when they're told by their bed partner or family members that the snoring's gone, they think they're treated. So I spend a lot of time with them in advance explaining snoring and sleep apnea are related, but you don't know that one's there because the other one's making noise. So we use ours a lot for that sort of thing. Of course, we need to reach out to our medical colleagues for collaboration, and that has been difficult for lots of us. But officially, I think it's considered to be a clinical screening tool that, while it's quite, I use the Brabon watch, while it's quite technical, there's a lot of new technologies coming along, but don't look for leadership from our college or our association. That's my opinion. That's my opinion. And I still pay dues every year. Okay.
So Dr. Sanjeev Jain is a sleep specialist in Ontario.
Right.
He's unique in the sense that he's a primary care provider and a sleep specialist. So as a dentist, you can refer directly to him,
Right.
compared to other sleep specialists that you can't refer directly to. But
Right.
the sleep image ring is approved for screening. So that should be okay to use.
Actually, it's improved. It's FDA approved for diagnosis. Actually, it's as good as a PSG. It is a really good tool, but okay. I sat on a committee in Ontario, and you all, because it's the land of polysomnograms, nobody's keen to use ambulatory testing. We had talked about 8 sats. way back over a decade ago, and there hasn't been uptake. I think that with COVID and restrictions or whatever, there's probably more awareness and more openness. Stay tuned. I think as the disruption in technology continues and sleep medicine changes, I still think things are going to change a whole lot in the next decade.
Yeah, me too.
Great. I have a patient who I sent for myofunctional therapy. Sleep improved, but child still wakes once per night. Normal sized jaws and no tonsil adenoid tissues. What would your recommendations be for next steps? You want me to repeat it?
No, I got it.
Okay.
I would do more nasal airway clearance, and I would wonder about allergies or asthma.
Okay. Dr. Heit, anything you want to add?
So, sorry, one more thing to add. Sorry, Dr. Heit, I apologize. Any maintenance insomnia. So if you have someone that cannot stay asleep in the middle of the night, sleepwalks or bedwets or any of those things, that is an airway problem. That garage size, either in form or function, is not sufficient. So what you're telling me is that structurally, the garage size is big enough. It doesn't mean that functionally or by form wise, it's not okay. There's inflammation somewhere in the airway from the nose all the way to the alveoli of the tree, and that needs to be treated.
Yeah, and just to add to that, like the child should be breathing through the nose with the lips sealed and the tongue up in the palate, silent and invisible. So no snoring, and that should carry on. Like it might look like it's developed fully and the tonsils and things aren't big, but you got to ask yourself maybe if both of them are set back. But it might be totally normal. And so like what Manisha said, that's where you go to your medical doctor. If the child's waking up once a night, what else is it? And I feel like you might get more information by reading Matt Walker's book, because there's a bunch of sleep hygiene things and all kinds of stuff they talk about in there.
I think the sleep hygiene is important, but there was a paper by Olivieri Bruni that looked at behavioral insomnia of childhood. And he said that behavioral insomnia of childhood breaks up into three things. There's reflux or gut issues. It's restless legs and periodic limb movements related to iron deficiency, or asthma and or allergies or respiratory issues. So not to brush things off as behavioral insomnia of childhood alone. And even in adults, insomnia might affect 40 million people, but even 1 out of 3 people as adults have sleep apnea. So if you have sleep maintenance insomnia, you have to rule out sleep apnea. That's the take-home message. The garage still might not be good enough.
Do a test.
It's been very enjoyable. Yeah, I've enjoyed it. It's good. What do you do for patients that have, you talked earlier about class 4, and that's the first time I've heard that term. I like it. It's great. Because I have seen patients where it's like both upper and lower pushed in, right? It's like somebody just pushed their whole face in.
They have a garage for a smart car.
Right. Yeah. But it's not just a maxillary or a mandible. It's sort of both. And so, so how would you recommend the management of that? Like, I was chatting with a colleague, orthodontist friend of mine, and it's like, is it possible to, to do a face pull headgear and then follow that up with a lower to kind of bring the mandible to catch up to that maxilla? Or I'm just wondering what your thoughts are.
We've had a few cases like that where
really
we've done that. Often, sorry to interrupt, Tam. What has happened is that the kid has developed mid-face deficiency after needing CPAP for sleep apnea, and they have pulled some of that forward. And sometimes that still requires maxillomandibular distraction because some of them have an underlying genetic syndrome or whatever. I'll give you your dental perspective on that.
So what I do is just get the diagnosis first. So you notice they're both set back, but the question is, what is the number one diagnosis? Is it possible sleep apnea without the diagnosis? So what you do is get the sleep apnea diagnosis, and then you just treat that. And the sleep apnea goes away, you're correcting whatever it is that made it go away. If the tongue fixed it, then you've done it in a non-inflammatory way by developing the maxilla, allowing the bottom jaw to come forward. And that's how this device and this concept works. You can use inflammatory methods like, headgear, and take it a step further, just jaw surgery, just cash register both of them forward. But I mean, that's already been done. And she just told you what happens.
I think it's a multidisciplinary collaborative thing, and we got to develop these things over time to see who needs what. As personalized medicine evolves, it's to do the right treatment for the right patient at the right time for the right reason, right?
Yep.
So I'm sorry, it's a complicated question with a complicated answer, which I don't know that we have all the answers yet.
But
So it sounds like it's maybe the least, try for the least invasive approach first,
Yeah.
and focus on relieving them of their symptoms. That seems,
yes,
yeah,
exactly.
Reasonable.
Treat the sleep apnea and see what you have later. And sometimes I'll refer to it like in adults, like baking a cake. The adult comes in, they've got, maxillary deficiency and crowded teeth and a deep bite and everything like that. But their number one diagnosis is sleep apnea. So you treat that first, that's baking the cake. And then the teeth, that's the icing on the cake. That's the pretty part. So first you bake the cake and you don't ice the cake before it's cooled, right? So you don't just treat them and they're, oh, my headaches are gone and my sleep apnea's gone. You got to let it cool, like leave them there for 3-4 months. Then you line up the white things. That's icing the cake. Bake it first. Yeah.
I think I heard something about a lady called Mother Nature. Is she kind of, she's involved in that too. Okay.
My question is, when you start treating kids to improve their airway, when do you see the stopping or the losing of bedwetting or night walking or night terrors?
When, like in general, you mean, or after you start treatment with Dr. Heit stuff?
Yeah, because if you ask medicine, 10% of the bedwetting gets better after 1 year.
Yeah,
But if
15,
you ask
yeah.
dentistry,
Yeah.
it's 90% after 6 months or something like
Yeah,
that paper.
Yeah, the paper, you know what, it depends. Again, it's multifactorial, right? There's genes and environment involved and family history and a bunch of things. It depends on what the underlying reason is. But in terms of time span, if their bedwetting is in that 6, 7, 8, 9, 10-year-old, and you've already fixed the class, whatever, malocclusion deficiency, whatever, and they're still doing that, there could be other medical reasons. I had a 16-year-old boy who had been to the urologist and the dentist and the ENT surgeon and all these people, and he actually had epilepsy. He is bedwetting because he had epilepsy. So nocturnal seizures occur in 25% of people just at night without any daytime manifestations. And this is going back to, med school or dental school. The homunculus, in terms of where the innervation is in the bladder, they're kind of, in that same spot. So sleepwalking and the bedwetting and all of that can come together, and nocturnal frontal lobe epilepsy can be a thing. I think it's important if the outcome isn't what you think, despite the treatment that you've done, and the child or whatever adult didn't respond like you'd expect, go back to the drawing board, because we got to problem solve again to say, okay, think and wonder, what are we missing? We did what we were supposed to, and I expected resolution, and there isn't. And just like the tonsils and adenoids, if the snoring is still there after they're done, there's still something wrong with the garage and it needs assessment.
So like the clinical trial I have in front of ethics right now is the treatment of bedwetting with a dental device. And we're going to have 90 kids, 45 are going to get treated and 45 are going to be controls. And after 6 months, we're going to see what happened with the treated and the controls. We're going to take sleep studies, do rhinometry to measure upper airway resistance. We're going to do models to measure 2D dimensions and cone beam CTs to get 3D bone volume and stuff before and after treatment, and both the treated and the controls. It'll be a very specific protocol. And, if somebody has seizures or whatever, that it's going to be like this group of people. And we want those metrics. Like when we do these sleep studies, I know from doing hundreds of these sleep studies that in spring, when the snow, when you have like pollen and stuff, everybody's sleep apnea is worse. So do you panic as a dentist?
Yeah.
I think it's going to give us so much information about what to do with these patients to answer exactly that question you just said. So the idea that this device or this Vivos Care treatment is FDA cleared, means they have the beginning of a protocol that, and I'm saying, whatever you use, if you use an ELF or a Schwartz or whatever thing that you use for maxillary development, think about doing it in a non-inflammatory way so that it doesn't hurt, so that it's just in there for part of the day and not the whole day. Because maybe that's the holy grail. Maybe we've got like a choice of 10 appliances to do the same thing. We just need the protocol. But I believe clinically that the 3D axial springs help develop the bone, the 3D osteogenesis, which changes the entire maxilla and not just sort of, just expansion. It's development of the whole shape and size of the maxilla. We see it in photos, we see it in cone beam CTs, but it doesn't mean that dentists haven't been doing something really helpful for decades. So we all need to get that data. That's why I'm dying to hear Mohammed's gagging thing, because that's a great idea. And if you get results and data, you gotta publish it. And you can learn how to publish and how to take that data and put it into a journal at ICMO, which is International College of Craniomandibular Orthopedics. You do your fellowship and your mastership, and you'll be publishing and putting in journals as a general dentist.
So thanks so much, ladies. And thank you folks for joining much, and we'll see you again soon. Bye now.
Okay.